wild flinging movements that are Okay, now let's talk about a few movement disorders, and we've kind of grouped them all together here. The first one we'll talk about is hemibolismus, which is caused by a lesion in the subthalamic nucleus, which leads to loss of inhibition of the thalamus by the inhibitory pathway. These patients usually will present with unilateral wild flinging movements that are contralateral to the side of the lesion. Hemibolismus can be often very severe, and when it is, it prevents daily activities. The first method of treatment usually involves anti-dopaminergic drugs. Now, I don't know if you guys are familiar with this dance trend, the new dance trend called the Harlem Shake, not the old one from like the hip-hop 90s, the new Harlem Shake. If you take a look at those videos, that dancing motion, that is what hemibolismus reminds me of. So I use that to think about hemibolismus. It actually also leads quite nicely into our next movement disorder, which is chorea. Now, chorea is Greek for dancing, and that's actually describing what these movements look like. They are dance-like motions, and when you see chorea, you should think of a basal ganglial lesion. Now, chorea is one of the defining features of a disorder that we actually just discussed. Which disorder is it? The answer is Huntington. Next, we want to discuss athetosis, which is sometimes described as snake-like movements, meaning that it is slow and writhing. It is also suggestive of a basal ganglia lesion. In what disease that we mentioned would you expect to see this? Again, you could see this in Huntington disease due to the damage of the caudate that is a part of the basal ganglia. One feature that can often distinguish it from other similar movement disorders is that it can be seen in the fingers as the convoluting, writhing movement of the fingers. Myoclonus is a sudden, brief, involuntary muscle contraction. You can also think of it as sort of a hiccup. You can also get this type of contraction in myoclonic seizures. The cause of myoclonus is not well understood, and although it is usually benign, it can be a symptom of a variety of diseases. Dystonia is a sustained, involuntary muscle contraction. This is something like writer's cramp or torticollis. It can be hereditary, but can also result from a variety of causes, including the use of neuroleptics. There is no cure available, and there is no standard treatment. Treatment, however, is aimed at reducing symptoms and is usually arrived at through some trial and error method. There are very good examples of all of these disorders on YouTube. You should really take a look at them and really get a sense for what the differences between these are. And don't forget to check out some of those Harlem Shake videos. Alright, you guys know what time it is. It's time for a flash quiz. Now, how does dopamine affect the direct pathway and the indirect pathway? Dopamine from the substantia nigra acts on the basal ganglia to activate the direct pathway and inhibit the indirect pathway. And overall, this will lead to a facilitation of movement. Okay, now let's talk about tremors. Tremor is a rhythmic oscillating movement of agonist and antagonist muscles, and there are three types. An essential tremor, which is the most common type. It is most prominent when the patient's limb is held in a specific position and disappears at rest. The tremor increases with stress and decreases with alcohol and beta blockers. Let's watch a video of this movement.
Okay, Gene, can you hold your hands out in front of me? Spread your fingers apart.
Okay, so I hope you could appreciate the tremor in her left hand especially. And of course, what this person would need in that situation is alcohol. So the second type of tremor is a resting tremor, and that is worse at rest and disappears with movement. Now, Parkinson's disease, as we've already discussed, is characterized by a special type of resting tremor called the pill-rolling tremor. Let's take a look at that here. Lastly, we'll talk about intention tremor. This is brought about by tasks like the finger-to-nose task or the heel-shin task. And do you remember what these tasks are testing again? What part of the brain? Cerebellum is involved in making these coordinated movements. But with an intention tremor, these patients cannot move their limbs in a straight trajectory and frequently overshoot or undershoot their target. An intention tremor can be seen in a number of neurological disorders. However, it is often mentioned in the context of a specific neuroautoimmune disease. Do you remember which one? That would be multiple sclerosis. Now remember that multiple sclerosis is a type 4 autoimmune disease, and we'll mention that a little bit later. However, while we are on the topic, are type 4 autoimmune diseases antibody or cell mediated? They are cell mediated. And that, folks, is called integration. Okay, now let's talk about the cerebral cortex. Now this is the part of the brain that really separates us from the other animals. It's the part of the brain that makes us who we are. It's where the thinking, the planning, the judgment, and all of those quote-unquote executive functions happen. So thinking about the cerebral cortex, it can be divided into 4 lobes. You have the frontal lobe, temporal lobe, parietal lobe, and the occipital lobe. And generally speaking, these all have different functions. For example, in the frontal lobe, you'll find the precentral gyrus, which is where the primary motor cortex is, while in the parietal lobe, you have the postcentral gyrus, which is where the primary sensory cortex is. The temporal lobe is important for hearing, among other things that we'll talk about, and then the occipital cortex is known for its role in vision. The dominant hemisphere, which is usually the left hemisphere, contains Broca's area, which is an area that's known for producing speech. It also contains Wernicke's area, which is used for comprehension of speech. Broca and Wernicke's area communicate to each other via the arcuate fasciculus. Now, lesions in the arcuate fasciculus can present with problems repeating sentences, but we'll talk about this in more detail a little bit later. Something I want to briefly mention before we move on is the difference between the left and right hemisphere of the cortex. Now, this is certainly a simplification and is largely based on data from right-handed individuals, but generally speaking, one can think of the left hemisphere as controlling things like speech, logical reasoning, math, science, whereas the right hemisphere would be known for controlling things like visuospatial functions, art, so music, drawing, things like imagination. So this is something to think about when you're reading a vignette where the patient has some cognitive deficit. The homunculus is basically a topographic map correlating an area of the brain to the body part it corresponds to. There is both a motor homunculus along the precentral gyrus, which is what we discussed in the earlier slide, and then we have a sensory homunculus, which is along the postcentral gyrus. Now, it is not correlated to the size of the organ, but rather to the amount of brain tissue devoted to controlling a particular area or receiving sensation from that region. That is why certain areas of the homunculus, like the face, or the hands, or the feet, are abnormally large. You should remember that the legs are medial, seen here, but the hands are more lateral. An easy way to think about this is that the homunculus is really an upside down person. So if you take a stick figure and you drew it upside down, right, you'd see the legs end up more medial, the hands are pretty lateral, and then the face is really lateral, upside down face. Step 1 loves to combine information about the homunculus with the distribution of the cerebral arteries. For instance, you should know that defects in movement or sensation of the lower extremities may indicate involvement of the ACA, or anterior cerebral artery, while defects in the movement of the mouth or the tongue may denote involvement of the MCA, exactly, which would be the middle cerebral artery. And we'll talk a bit more about these cerebral arteries later. Now, lesions can theoretically occur anywhere in the brain. The size and site of the lesion will determine the types of symptoms one will see. For step 1, there are a number of brain lesions you are expected to know, so you should make some time to review the chart in your book. As I've mentioned before, the main thing to remember when going through lesion syndromes are what the area that is lesioned is normally responsible for. From there, it should be pretty intuitive to figure out what the symptoms of that lesion would be. So let's start with a pretty famous lesion. This is Kluver-Bucy syndrome. And this occurs when the amygdala is damaged bilaterally. And this results in hyperorality, hypersexuality, and disinhibited behavior. Think of this as the Friday night fraternity party on your college campus. One gets these symptoms because the amygdala is important for generating anxiety and fear, which is important for inhibiting behavior. Think about something that you might want to do that you know is inappropriate. That feeling of hesitation that you get, that is generated by your amygdala, among other things. So if your amygdala isn't working and you don't have that sense of hesitation, then you're more likely to do this thing that you know you shouldn't do. Think about when you've wanted to do something that you know was inappropriate. That feeling of hesitation that you get before you do it or while you're deciding whether or not you want to do it, that is being generated by the amygdala, among other things. And so you could imagine if your amygdala is not there, you don't have that feeling of hesitation, you might end up doing that thing that could be pretty embarrassing. Hence the Friday night party that your fraternity throws analogy that I brought up. If there's damage to the right parietal lobe, you end up with something called a spatial neglect syndrome. Now this is a really fascinating condition. The patient has no understanding that a contralateral side of the world exists. Now try to think about that for a minute. It's like you're living a life where only half of your world exists, even though you're actually getting visual sensation from the other half of the world. So in a patient that has this disorder, you might ask them to draw a clock that says 4 o'clock. And so you put in the numbers, and they might draw something like this, where they completely ignore the fact that there's no numbers on the other side of this clock. The Wernicke-Korsakoff syndrome involves bilateral lesions of the mammillary bodies. This is commonly seen in patients who abuse alcohol. The Wernicke aspect consists of confusion, ophthalmoplegia, and ataxia. Now that's a classic triad that you should definitely be aware of. Confusion, ophthalmoplegia, and ataxia. From there, it can progress to Korsakoff, and this is where you will get memory loss. From there, it can then progress to Korsakoff, and from there you get memory loss, confabulation, and personality changes. Now, if you think back to your biochemistry, you remember that this syndrome occurs due to lack of a particular vitamin. Do you remember which vitamin this is? That would be thiamine, or a B1 deficiency. This is the main cause of Wernicke-Korsakoff. Thiamine deficiency is typically seen in chronic alcoholics, and this is why there is this correlation between alcohol and Wernicke-Korsakoff. We talked a bit about damage to the basal ganglia and cerebellum. Damage to the subthalamic nucleus, shown here, is responsible for causing contralateral hemibolismus. As we've discussed before, this is a very classic brain lesion. The hippocampus, as you know, is critical for memory formation. So, lesions to the hippocampus cause anterograde amnesia and inability to make new memories. Something important to remember about the hippocampus is that it is very sensitive to anoxic injury. So, if a patient has been without blood flow for a while or is unable to breathe for some time and you are asked about a brain region that might be damaged, the hippocampus should definitely be on the top of your list. The next two lesions deal with the visual system. Damage to the paramedian pontine reticular formation, or PPRF, will end up causing the eyes to look away from the side of the lesion. If, on the other hand, you damage the frontal eye fields, which is by the premotor cortex, you get the opposite result and the eyes would look toward the lesion. Again, you should really take the time to know what the different brain regions do. This initial effort will make it very easy to figure out what the different symptoms are telling you about which brain regions are likely involved. Alright, it's time for a flash quiz. What are Broca and Wernicke's area? These are both areas in the dominant hemisphere, which is usually the left hemisphere, and they are involved in communication. Broca's area is involved in speech production, and Wernicke's area is involved in comprehension of speech. And again, we'll talk about these a little bit later. Okay, so a patient comes to your office and is found to have nausea, vomiting, and a headache. You check his Chem 7 and you notice that his sodium is 125 milliequivalents per liter. Now, due to his hyponatremia, you decide to put him on food restriction, and then you give him salt tabs. The next day on morning rounds, he cannot talk and is unable to move in response to your voice. What the heck happened? Well, Despite the fact that you've now probably failed your internal medicine rotation, this patient has also developed central pontine myelinolysis. Now this has happened because of a rapid correction of his hyponatremia. The osmotic shift that occurs during this situation causes damage to the pontine neurons, and that leads to acute paralysis, dysarthria, dysphagia. You can also have double vision, and the worst thing probably, loss of consciousness. On an MRI, the diagnosis can be made, and it would show an increased signal in the pons. Now we've talked a lot about Wernicke and Broca's area in some earlier slides, and those are really important when it comes to thinking about aphasia. Now aphasia is simply the inability to speak due to a cortical lesion. You have to be able to distinguish aphasia from dysarthria. Dysarthria is a problem with the actual mechanical production of speech. Now, what is one test that you can use to distinguish between dysarthrias and aphasias? A good test is to actually have the patient communicate by writing. With an aphasia, written language is also impaired, whereas with dysarthria, because it's only a problem with actual mechanical production of speech, written language is maintained. So now let's actually talk about these areas. You should certainly be familiar with aphasias. Luckily, as with a lot of the information in this chapter, there's an intuitive way to approach this. If you think of where Broca's region is, you see that it's in the frontal lobe. And so you can sort of think of this as a motor area for speech, as the motor cortex is in the frontal lobe. So then it makes sense that their comprehension, although it's perfectly intact, they have trouble producing the words. This problem in production is equal whether the form of communication is written or spoken. As we mentioned before, this is a major way to distinguish aphasia from which other condition? Yes, dysarthria. In contrast, Wernicke's area is in the temporal lobe, in a region that is responsible for processing and making sense of sensory information. Thus, the problem here is not production of words, rather it seems that the meaning of language is lacking. There are a couple of good YouTube videos of patients with both Broca as well as Wernicke's aphasia, and you should check them out to see some good examples of these disorders.